It's great to see everybody, and it's particularly nice to welcome Alice Lynham, who's a Brit that did some research at Yale in Jenny Dwyer and Mike Block's group. So Alice was telling me that she did a master's course, I think, an unusual master's with the talk part in London and then the research part in Yale. She stayed for an extra year because she loved it so much, but is now back in Blighty.
Badly.
So she's going to talk to us today about exploring predictors of ketamine response in adolescent treatment of treatment-resistant depression. So welcome, Alice, and the floor is yours.
Thank you very much, Rupert. And thank you to you and Sarah for inviting me today. I'd never heard of the Journal Club, but I'm super excited to present and also attend some more of the meetings. So hi, everyone, and thank you for having me. My name's Alice Lynham. I'm going to be presenting on a paper that I wrote during my time at Yale, as Rupert said. I wrote it alongside Victor Avila Quintero, Jennifer Dwyer, and Michael Block, who I believe should be joining us today. And I, just a couple months after I joined Yale, Michael and Jenny had just published the first randomized control trial, which was using intravenous ketamine for adolescent treatment-resistant depression. So when I got there, I was quite interested in kind of looking into some different predictors that might be indicative of the efficacious effects that they saw in the RCT. So that's going to be what the current paper is going into in a little bit more depth. So I'm not going to go into too much detail on the kind of background of ketamine and its use in depression and treatment-resistant depression, because I know that you guys are all relatively well versed in the space. So I'm going to jump straight into ketamine and its use in the pediatric population more specifically. So we know that ketamine has been safely used as an anesthetic in pediatrics for over 50 years now. In terms of the adult literature, just briefly, it has demonstrated quite a robust antidepressant and anti-suicidal profile now. And more recently, reports have been begun investigating ketamine in the adolescent population.
Alice, sorry, I think you were muted for a moment.
And was I muted for all of that?
No, just I think maybe 1 minute ago or so.
Okay. Should I start from the beginning of this slide?
No, it was entirely my fault. Sorry, I was
no problem at all.
people and I hit the wrong button.
You're all good.
Just carry on. You're doing fine.
Are you bored of me already, Rupert?
No.
Okay, I'll jump straight into the single case reports. So Zaranegger and colleagues in 2018 released a single case report, and Dwyer and colleagues, so that's Jenny at Yale and her colleagues, also released a case report of a 16-year-old who went through a single infusion of ketamine, and this was shown to reduce their depressive and suicidal symptoms. Cullen and colleagues, again, based in the US, published an open label study. So this was with a few more participants. I believe there were 13 adolescent participants in this trial, and they underwent 6 infusions over the course of 2 weeks. And then finally here, or most importantly here in this study in blue, was the randomized control trial I was discussing earlier, so released by Jenny and her colleagues. And this was the first randomized placebo-controlled single-dose trial in an adolescent population. So notably, this is going to be the study I'm going to be discussing in detail today, because it's a study from which I conducted the secondary data analysis for the current paper. And then finally here, we have this multiple dosing efficacy and tolerability trial. So this is an ongoing trial at Yale, and this is the first control randomized multiple dosing trial. So it's kind of a follow-on from Jenny's, but with multiple doses over the course of 2 weeks. So yeah, as I mentioned, this one's still ongoing. So likely we'll hear back about those results in the coming years. So just to go into the RCT in a little bit more detail, again, as I said, this was the first RCT in a pediatric population. I'm not going to go into the methods in too much detail here because I'll go through it in a lot more detail later down the line. But there were 17 participants involved, all aged between 13 and 17, all of whom had a DSM-5 diagnosis of MDD. and all of whom were treatment resistant or treatment refractory. In terms of the intervention, it was a single ketamine dose followed by a single midazolam dose. So individuals would receive one and then the alternate compound 2 weeks later. And then most importantly here, the results. So what we found was that a single dose of ketamine demonstrated significant improvement of the adolescent's depressive symptoms as compared to midazolam at 1 day or 20 hours post-infusion. And these treatment gains remained on average for up to 14 days following the initial infusion. And then in terms of the proportion of responders, 77% had a clinical response to ketamine. And then just to delve into that in a little bit more detail. So as I said, 77% responded to ketamine. If we break this down into the numbers, that's 8 who responded only to ketamine and 5 who responded to both ketamine and midazolam. But importantly here, others experienced no relief. So 3 individuals experienced no relief with either compound, so either ketamine or midazolam, and 1 individual only responded to the midazolam control. So obviously ketamine is not 100% effective for everybody. If we look across to kind of comparative adult trials, we see a similar thing. So we see anything in the range of kind of 50 to 70% response rate and a relatively varying duration of symptom response. So what this kind of points to is a need for identification of subpopulations who might be more or less likely to respond to ketamine. So in terms of what previous literature looks like, which is investigating this specifically, so kind of various predictors or characteristics which might be indicative of response, we have here listed a few research papers from the adult literature. So higher BMI has been associated with greater therapeutic response, as has a positive family history of alcohol use disorder. The research is relatively contrasting in terms of intra-infusion dissociation levels. Anxious depression subtypes has been associated with a greater therapeutic response, as has absence of prior suicide attempts. Various biomarkers have been looked into, so genetic profiles, inflammatory cytokines. And then in terms of treatment resistance, and this is going to be of significance for the current paper, treatment resistance, just to kind of point out, is marked kind of differently in different papers, but most kind of primarily marked by fewer antidepressant trials. So if we look at these 2 papers here, they were published in the same year, but the results from them are contrasting. So one trial in 2022 found that lesser treatment resistance was associated with a greater therapeutic response, whereas this meta-analysis here by Price et al. Found the contrary. So they found that greater treatment benefit of ketamine was associated with a greater treatment resistance, so a greater number of previous antidepressant trials. This meta-analysis also looked into other things, so kind of BMI, enrollment in the US, and a crossover study design, all of which came out as kind of having a small moderating effect on treatment outcome. So that's the adult literature, but in terms of the adolescent field, the space is really quite new. It is new in adults, but it's even newer in adolescents. So there's only one study which has looked at kind of any sort of predictor in the adolescent population, and this was published by myself and the same group, published at the beginning of 2023, and this looked specifically into intra-infusion dissociation levels. But aside from this, there's no other research papers out there that I'm aware of that kind of delving into what might be predicting therapeutic response. So this is going to be really important to help identify, kind of present an opportunity for significantly improved clinical outcomes, and to kind of look into whether adolescents and adults share any predictors of response, and to kind of look into what might be some like important measures or components for future trials. So what might be some kind of reasonable predictors to include and to kind of focus on, in future research. So this leads us on to the current study, which is exploring predictors of ketamine response in adolescent treatment-resistant depression. So in terms of the methods, this is quite a busy slide, but as I mentioned, this was a secondary analysis of Dwyer et al.'s RCT. So just to go through some of these bits, So there were 17 participants enrolled, all of whom were between 13 and 17 years old. They all met the DSM-5 criteria for major depressive disorder and had a CDRS score of more than 40. All of the individuals were either treatment resistant or treatment refractory. So this was defined as for treatment resistant, failing 1 SSRI of adequate dose and duration, or treatment refractory being failing 2 or more SRI medications of adequate dose and duration. In terms of exclusion criteria, I'm not going to go through all of these, but some poignant ones. So no current hospitalization, no current suicidal ideations, and individuals had to be ketamine naive. In terms of medication details, participants were to remain on their standard medication regimens for 4 weeks before and throughout the 4-week trial period. But notably, if an individual wasn't on a medication, this like the individual did not have to kind of start medication for the purpose of the trial. In terms of controls and blinding, we utilized the active control midazolam, and we had various other measures in place to protect the blind. And procedure-wise, obviously, we were looking at adolescents, so participants had to be accompanied by at least one parent and a guardian who acted to provide informed consent, and the adolescents provided assent. To look more closely into the study design, so this was a 4-week study, and it was a randomized midazolam-controlled crossover trial. So infusion days took place on day 0 and day 14. So if you look here, this kind of zooms into what the infusion day looked like. So individuals were randomized to get either ketamine or the midazolam control, and they would receive one compound on day 0 and then the alternate compound on day 14. Blood work was taken at various time points for PK data. And in terms of the side effect rating scales, the CADS, the clinician administered dissociative state scale, was also taken at various time points post-infusion. In terms of the efficacy rating scales, the researchers wanted to talk to the kids quite a lot. So the rating scales were taken on all of the days listed here. But the primary outcome measure of note was the MADRS at day 1. So this is a Montgomery A depression rating scale. And then for this secondary analysis, we use MADRS scores from baseline or day 0, day 1, and day 7, and then the same for the crossover phase. And then we got the data for the clinical and the demographic information from the baseline or the screening days. To go into a little bit more detail into the measures, so as I said, the primary outcome measure was the MADRS, and we utilized the scores from the baseline, the day 1 and the day 7. Notably, a responder was defined as having more than a 50% reduction in their MADRS score at any time point in the first 3 days following their ketamine infusion or their midazolam infusion. And why did we kind of pick the MADRS? Largely due to its kind of previously demonstrated sensitivity to the acute antidepressant effects of ketamine, but also due to its kind of reliability and validity, which has been previously evidenced in depression trials with adolescents. In terms of the subject level predictors, so you can see here quite a few socio-demographic and clinical variables listed. So I don't need to read these all out, but of importance here is kind of the baseline CDRS and MADRS scores, the CADS score, the age of depression onset, the duration of the current depressive episodes, the number of previous pharmacological antidepressant and augmentation treatments, current use of an SSRI, current use of an SNRI, a couple of comorbidities were investigated, and also a family history of depression.
What's a mask?
The mask, it's an anxiety rating scale.
Okay.
So if we go on to the results here, I'm going to show you 3 result slides. They're not very pretty. I don't have any nice sort of like graphs for you, I'm afraid. So we've just got tables to work with. But this first table shows the clinical characteristics of both responders and non-responders to ketamine and midazolam separately. So what we see is that those who responded to ketamine had both a shorter current duration of a shorter current episode of depression. They had fewer previous antidepressant and augmentation therapies, they were more likely to be taking a current SSRI, whereas those who were taking an SNRI currently were less likely to respond to ketamine. If we cross over to the midazolam phase, we see that those who responded to midazolam had a lower baseline CDRS score as compared to those who did not respond to midazolam. And there were no kind of clinical characteristics which overlapped between ketamine and midazolam, so which showed a significant association with both ketamine and the midazolam control. If we look here, this shows the correlation coefficients for the associations between the characteristics and then symptom improvement at day 1 and day 7 following the ketamine and the midazolam infusions. So we can see that fewer antidepressant therapies were significantly associated with a greater depression symptom improvement at day 1 and at day 7. And fewer augmentation therapies was also associated with greater symptom improvement at day 1, but this was not seen at day 7. Then if we looked at the midazolam findings, again, we can see that baseline CDRS was associated with a greater improvement following midazolam. This was seen at day 1, but not day 7, as was having comorbid ADHD and a family history of depression. So these were both associated with a greater response to midazolam at day 1. And then finally here, we can see the moderator analysis, which examined the baseline clinical characteristics, which were associated with the ketamine infusion as compared to the midazolam infusion at day 1 and at day 7. So the main finding is that fewer number of past medication treatments, a fewer number of past medication treatments was associated with significantly greater depression symptom improvement at day 1 and at day 7. And fewer augmentation treatments was associated with greater improvement at day 1 and at day 7. And finally, subjects currently being treated with an SNRI experienced less depression symptom improvement with ketamine at day 1 following the infusion. So if we just kind of look at that, if we zoom out a little bit, we can see the key results listed here. So ultimately, individuals were more likely to experience symptom improvement with ketamine if they had fewer antidepressant and augmentation treatments, if they had a shorter duration of their current depressive episode, and if they were currently being treated with SSRI medications and not SNRI medications. And if we look at the midazolam control findings, we see that individuals were more likely to respond to the midazolam control if they had comorbid ADHD and a family history of depression, and if they had less severe depression scores. Now, if we look at what this means in terms of clinical significance, if we look at the finding that adolescents who were treated earlier in their depressive episode and had fewer medication trials were more likely to respond to ketamine, we can compare this to some of the adult literature. So we can see that it's in line with some adult findings, but it does conflict with other findings. I outlined these findings earlier. This was the individualized participant meta-analysis, which found that kind of greater treatment response was associated with greater with a greater number of previous antidepressant medications. And if we look into potential benefits, what we can see that if the current findings were to be replicated, then it's possible pediatric patients could benefit from ketamine treatment at an earlier stage in their depressive disease course, which could potentially prevent individuals from progressing into more chronic and persistent forms of their depression. In terms of current practice, we typically reserve ketamine treatment for those who have responded to a previous SSRI and then a previous course of psychotherapy. And more often than not, this will also be non-response to 2 SSRIs and potentially the addition of an augmentation therapy on top of that before we even consider treating individuals with ketamine. Obviously, this is kind of current practice in the US. I don't actually know whether adolescents are treated here in the UK. I'm aware of one adolescent participant, but it would be quite interesting to actually discuss that in more detail following this presentation, because I'm not too aware of what that looks like here. but yeah, but ultimately, if obviously the data here is preliminary and exploratory, we're working with a very small sample, but if the findings could be replicated, we could possibly be advocating for a kind of reconsideration of current recommendations to reserve ketamine treatment for the most severely treatment-resistant individuals. If we look here at another clinical significance area, so if we look at the medication type and ketamine response finding, so just to go over that again, we found that adolescents taking an SSRI and not an SNRI were more likely to respond to ketamine treatment. So we outlined two different explanations in the paper, but importantly, explanation one is the one that us authors did advocate for. So we thought this was perhaps due to the correlation between current medication use and degree of treatment resistance. So SSRIs are typically the first line treatment in pediatric depression, always in preference to an SNRI. Now, this is in contrast to the adult population where both medications are considered first line for depression. But again, this might kind of seem to point to the notion that those who are less treatment resistant may be more likely to respond to ketamine. However, we can't entirely discount the possibility that explanation two explains the current findings, and that's more concerned with the kind of possibility of there being interactional effects with the compounds. So, for example, could the SSRIs be enhancing the effects of ketamine and SNRIs doing the opposite, for example? It would be relatively difficult or impossible to kind of preclude this notion with the current data set, given the preferential prescription. So we'd likely need to kind of gather data from the adult population, again, where kind of there isn't this prescription of an SSRI or an SNRI preferentially over one or the other. So then if we look into some of the limitations and some suggestions for future research. So we were working with quite a small sample size of only 17. So we did have limited power to detect predictors of ketamine response. With this in mind, it is possible we didn't actually uncover meaningful predictors. Additionally, analyses were secondary analysis of the clinical trial, and they weren't corrected for multiple comparisons. So they should be, our findings should be considered exploratory and for kind of hypothesis generation more than anything else. We did uncover a relatively limited number of predictors, so other than duration of current depressive episode and a greater number of failed medication trials, we didn't really uncover any significant findings. So future research could potentially look into biomarkers or blood metabolites. And then finally, it's still quite unclear how these predictors of ketamine response in a single dose trial will generalize to a repeated dose paradigm. So there are ongoing trials at Yale, which are using multiple doses. So hopefully in the next year or so, we might have some more conclusive findings. And then just finally, to finish up some conclusions and final remarks. So just to go over the key findings, some potential predictors of ketamine response in pediatric treatment-resistant depression include lesser treatment resistance, shorter episode duration, and current SSRI use. In terms of clinical significance, current practice reserves ketamine for non-responders, but replication of findings may prompt reconsideration of these treatment recommendations. And then just finally, we do emphasize caution. Obviously, this research is really in early stages, and these predictors are not yet suitable for any kind of clinical decision guiding. There's a significant need for kind of more extensive further research before any of these findings can impact clinical practice. But yeah, I think this is really important because although we know that we do need new treatments urgently for pediatric depression, we do still have kind of other interventional treatments like RTMS and ECT, which have considerably more safety and efficacy data linked to them. So we don't want to be kind of administering ketamine to individuals, to all individuals, if it's not going to be efficacious for everybody. And then just finally, some brief thank yous to Michael, Victor and Jenny, and then just some key references to finish off. Thank you very much for listening, everyone.
Great. Well done. Thank you very much indeed. That's terrific. So fairly straightforward findings, and it's open for everybody to think about. You can put your questions in the chat if you like, or stick your hand up, or do whatever you like to draw attention to this. Perhaps I'll kick off with the first question before we go to Dr. Chang's question. But you just on the methodology, you talked about protecting the blind, and there are various measures taken to do that. Can you say anything about how you did that?
Yeah, definitely. So firstly, participants were randomized to either the midazolam or the ketamine. So that was kind of the first method. Obviously, we utilized the midazolam control for various different reasons. Midazolam has kind of a similar pharmacokinetic profile as ketamine. It's fast acting. It has a short half-life. It can be delivered intravenously in the same way that ketamine can be. We see kind of like similar changes in the subjective state and the cognition and kind of like other noticeable effects on kind of perception. So we see that with midazolam and ketamine, individuals can experience kind of being spaced out and kind of this like detachment from their body. But there is still kind of a lot of questions surrounding whether midazolam is an efficient control because individuals experience significantly more dissociation on ketamine. They experience a lot of kind of like a dreamlike state and the slow motion kind of aspect that's not typically seen on the midazolam control. So pending as to kind of whether that is the most effective control. And then we did follow up with a subset of participants using a guess form in which they would kind of indicate whether they thought they had got the control or the kind of active compound. And it is important to point out that 100% of individuals who received ketamine did guess that they received ketamine correctly. So whether it was effective control or not is kind of up for debate. And then otherwise, in terms of protecting the blind, we also had separate safety and efficacy raters. So the study took place at the Yale New Haven Hospital. And the way it worked is that the efficacy raters would never be present at the infusions. So they would only be taking the kind of MADRS ratings either before or after the infusion, and the effects of the infusion had subsided, just to kind of like limit the unblinding, any functional unblinding on the part of the researchers. So yeah, they were the main kind of blind maintaining procedures we had in place.
Great, thanks very much. Okay, that's good. Let's go through some questions here. So for the ketamine responders, did you look at the duration of the antidepressant effect? And how does that compare with the duration for adults? You've got I know this would be perhaps something from the primary trial. I see we've got Mike here, so if he wants to chip in at any point, you're very welcome.
Yeah, please do chip in, Michael. So we the 14 days was the longest time that we followed up with these individuals in this trial. So yeah, just the 14-day mark.
I would say it's very little data to get a range. If anything, the ketamine responders probably were a little longer than what you see in adults. So I don't think we don't have like a good comparison group. But I think on the whole, it was quite similar. And just to add to the blinding of ketamine and midazolam, I was at, I think, almost all of the 17 treatments, and I can, I was a safety person, so I was monitoring the safety of the study. I can tell who gets what. It's not, if you're watching their vital signs, it's not rocket science. That if you get ketamine, your heart rate and blood pressure goes up, and if you get midazolam, your heart rate and blood pressure goes down, and then you have the difference in dissociative symptoms. So I think the only way you can get around it is being kind of like a therapy trial and having separate raters, which we did, and it's not perfect.
Okay, thanks. Yeah. Tiago asks, everyone in the group was on medication. Was everybody in the trial on medication? Was there anybody who wasn't taking an SSRI or an SNRI?
Yeah, I think there was, so of the sample of 17, there was 2 individuals who were not on any medication at all, but kind of 9 or 10 of them were on an SSRI and relatively similar for an SNRI. So most individuals were on some sort of antidepressant medication.
Okay, so the group was sort of split, which is quite nice to be able to. It's fortunate.
So I think there might have been one person who wasn't taking any medicines at the moment, but I don't. But they had failed multiple times in the past.
Yeah. Okay. Okay. Julia says, were they receiving therapy of any kind as part of the study, and are there any long-term follow-ups planned?
I can't speak to whether individuals were going through therapy at the time. Maybe Michael, you can. But in terms of the follow-up, there are some ongoing trials at Yale now, which embeds a CBT follow-up within the trial. Maybe you want to speak a little bit more to that, Michael.
Yeah, so I think we tried to keep everything as stable as possible, and so basically during the 4 weeks of the trial, they might have been seeing an outpatient therapist, but they weren't getting anything from us in terms of therapy. In the repeated dose study, we definitely have a therapy component at the conclusion of the ketamine treatment, where they get sort of structured CBT at the end of the trial to see if we can kind of keep the response going if they're not getting the ketamine anymore. And I think if you're asking how to use it clinically, I think a big part in the clinical treatment and the repeated doses is making sure kids have sort of the ideal therapy condition, not really like anything specific to the treatment, but not anything specific to the ketamine, but more in improvement in their depression, because at least my guess, and I don't have any data to back this up, is that when you have a child get a lot better in terms of their depressive symptoms over a short period of time, it's really important to have some support around that and help in sort of maximizing the treatment gains, and then also dealing with the stresses that come back in these adolescents' lives a lot of time when they like become undepressed. A lot of them are severe enough that they missed a ton of school, and now they're facing making up all this work in school, and having I think having that relationship and that support is sort of critically important in the kids getting better, not specific to ketamine.
Thank you. It just prompts me to ask a question. Were there specific depression items that you think were more likely to respond? So, for example, was there a group for whom motivation and energia improved, but they continued to say, no, I'm still very depressed?
We didn't look into symptom clusters, did we, Michael?
I don't think we have yet. I think the problem is we have so few kids. I think in the larger like things like the repeated dose as ketamine study that Janssen's doing, that would be a good thing to look at. In our R1, I think it would be a good thing to look at whether there are particular types of patients. I think particularly more severe suicidality is probably something that, I mean, I think there's good data on, not specifically from our trial, because we're taking people who are relatively low on that end in this trial.
Yeah, no. Well, in this forum, we like speculation. It's all okay. Anyway, that's helpful to hear.
You want? I'm happy to speculate more, I think.
Yeah, great.
One on another. But I guess the big thing I'd say about this is just the thing that I think is really sort of frustrating in treating these kids in sort of the interventional psychiatry is the length of time the kids are often going without getting good evidence-based treatment, and then how sort of disruptive the depression gets in their lives. And I think sort of my sense of the data as a whole is it may be, my guess is that ketamine's an effective intervention for adolescent depression. Time will prove it out longer term, but that in these kids who have sort of more refractory depression that's gone on longer, it's harder to get them to move. And I think that it may not be anything specific to ketamine as a compound that's doing it.
Just getting in early, yeah.
And so it makes you think about this sort of, I don't know, I don't know how it is in the UK, but I feel like a lot of time doctors aren't really taking the kids with severe depression seriously, and they go 3 years and try 6 SSRIs.
Yeah, absolutely.
Yeah.
The same.
Um,
It's just the same. Yeah. There's a question here about anhedonia. Are you going to be measuring anhedonia in your future study specifically?
so Alice, do you want to take this or do you want me to take it?
I don't believe we are studying anhedonia. I mean, I'm not involved in the current trial, so you may as well take it.
So there is a secondary measure that we get, not at like all these time points like in this study, but we have, I forget the anhedonia scale. Maybe it's a pleasure scale for children or something like that. Maybe making up a scale.
So the SHAPS is not suitable for kids, is that right? Or is it different? Anyway, yeah.
But we do have a few measures of more sort of additional constructs. So I think anhedonia is one. I think sleep is probably particularly important in kids,
Right.
and how that's managed. And then irritability is going to be another one that's really important to look at in kids, because I think depression in kids has, I would say, more irritability associated with it. I'm not sure necessarily in this study population we're going to get, but in these studies, but I think you see that a lot.
And just anecdotally, I mean, apart from the irritability, what was some of the other challenges of working with adolescents?
Well, obviously that they have parents, and but I mean, just so I mean, the challenge in working with adolescents and with this with the I think patients with depression and suicidal ideation in general is the morbidity of the illness, and that we don't get everyone better. And we've certainly had patients. One of the patients in this trial, died by suicide long after we treated it. He was involved in this trial, but and we've certainly had adolescents in our other trials where that's happened. I think that's the hardest thing about it, is that it's really I think the morbidity in the sort of the population that we're choosing to treat in these studies is really high. And I think at least I find that really hard, and I think you as a team have to take that really seriously and really do the best you can clinically with the kids when they're in a long-term trial, making sure they're getting really good therapy on the side of things, because I think bad outcomes happen, and I think it's at some level you have to be you can't be okay with it, but you have to somehow be able to live with that and continue to try to find better treatments. And I think the only way to do that is to really try to do the best you can in terms of the care.
Do you have a mechanism for continuing treatment after the study in people who improve but then relapse?
So this is one that's a big issue for us, is that short answer is that the FDA in these trials is currently limiting it to 8 treatments in kids. So we cannot, even though we've wanted to include a relapse thing where the kid relapses after they get a certain number of doses of ketamine, putting that in the design, we're actually not able to do that, because for reasons that I must say I don't 100% agree with, the FDA is more concerned with the repeated ketamine exposure in kids than the death by suicide. When at that point, it's been an effective treatment for them, because we wouldn't be doing it if they hadn't responded. So
The FDA has control over what you can study in the States, does it?
Yes. So like every time you have to get an IND application if you're going to do a study at a university. I think I could do this outside of the university, outside of the FDA, and perhaps get around it that way, but I don't think you could do it. I strongly disagree with it, but because I think for the reason that it's also, kids are getting a lot more treatments clinically and getting repeated doses well beyond the 4 or 8 or whatever we're going to do in a study, and certainly beyond what the FDA does. And the fact that you can't really get safety data on that is a real issue if you think it's an issue. then I guess the last thing just to emphasize, I think a lot of the again will be very interesting to see from the repeated dose studies in kids particularly, but my experience has been that a lot of the kids, when their depression is better after repeated infusions, can maintain the treatment benefits. That being said, I think you've already figured out that I think the standard of care treatment that we're giving in the trials is much better than what, in my opinion, is probably much better than what they're getting in the communities, because I think the quality of psychotherapy, that standard of care, is often not what people are getting in the community, and same thing with medication management.
Okay, thank you.
Can I ask a question? Before I slip from my mind, Alice, thank you for the presentation. It was very clear, great work. I'm of course curious if you can even comment a bit on your other paper with the CADS finding. But I was also wondering, because this is an adolescent population, and I know you guys were excluding for acute suicidality, but I was expecting, I don't know, maybe some information on self-harm. I hope I haven't missed that. And I also was wondering if you considered among the predictors the use of the total amount of ketamine they were exposed to. I assume you were like dosing the 0.5 milligram per kilogram, but of course this gives a bit of variety in terms of based on the body weight of the patient and if that has any influence at all.
Yeah, of course. I'll start off by discussing the CADS findings in a little bit of detail. So I basically wanted to look at whether the subjective effects of ketamine were associated with any kind of therapeutic response. So I was using the same data set, but rather than looking at predictors, I was looking at the CADS scores in a lot more detail. So I was looking at, I took the CADS scores from the 60 minutes after the infusion and then took the MADRS day 1 and day 7 scores. And then kind of just did various associations and correlations. I didn't find any significant findings for this trial. So intra-infusion dissociation was not associated with therapeutic efficacy. I also broke down the CADS into the 3 different subscales. So I looked at kind of the depersonalization, the derealization, and the amnesia. And again, didn't find any significant findings. But yeah, I was just quite interested in dissociation because there's been quite a lot of mixed findings in the adult literature. Like it's been pretty split in terms of papers which have found that dissociation symptom reduction does correlate, and then ones that don't. And then also you've got kind of the psychedelic literature, which is really kind of advocating for the kind of drug experience and how that might be kind of like quite essential to the treatment effects. And then just to kind of, on top of that, there's also sort of a lot of research in terms of like the other NMDA receptor antagonists who kind of don't have the dissociative side effects and have failed to show any sort of like comparable antidepressant effect. So I think kind of like all those things combined really led me into thinking that there would be some sort of significant effect there. And I was quite disheartened to find out there wasn't. But yeah, it was a fun paper to write anyway, so I'm glad I did it. And then yeah, Michael, if you want to maybe take the question on the different dose levels.
So I think we had metabolite data in the subjects that we're still working on. My sense, if I'm allowed to speculate, is that if you're looking at the metabolite levels, my sense is that there wasn't anything associated with the particular blood levels of ketamine after the treatment that was associated with response. The main thing, and again, it's not ready for prime time yet because I need to understand one of the metabolites better, is it seems like the more effective that people were in metabolizing the ketamine to the inactive metabolites, the less likely they were to respond. So there may be, and it'd be really interesting in larger data sets where I assume they have blood levels too, whether there's anything going on, because again, our sample is so small.
So Mike, when you say more effective, you mean that they would metabolize that faster?
Yeah, that the ketamine was on board for probably less time, that they had the higher concentrations of the inactive metabolites at the later time points was the thing that was associated with non-response. So, and I think you're on the right track about this. If you're doing weight-based dosing, this BMI stuff, or how much sort of how much you're doing ideal body weight versus actual body weight is probably going to be a important factor in things. And
just sticking with the CADS for the moment, was there a significant difference in the CADS score on those who were on SNRIs and SSRIs? I know that there's a sort of notion that I think with psychedelics that SSRIs would reduce your chances of dissociating, wouldn't they? But did you know? Was there anything in the data there?
We actually didn't carry out analysis on that.
And a question about whether you think that that was to do with the insensitivity of the CADS and whether an altered states of consciousness scale would be better for your longer study, for your bigger study.
Yeah, I would completely agree. I think quite a few studies have shown that the CADS only partially captures the actual effects of ketamine and the subjective experience. I mean, as a kind of tool, it was first developed for like PTSD patients, which may kind of be representing a very different kind of dissociation than a drug-induced one. So I'd say that it is probably quite an imprecise measurement. And I think there are just so many difficulties of like assessing people in an altered state of consciousness. But there are kind of now some dedicated scales, as you said, which do kind of measure like the acute effects of hallucinogens. So I wonder whether these would be kind of better suited for future trials.
Yeah, I think anything to get us doing repeated CADS ratings in these studies
Yeah.
would be a good thing, because I think it also encourages unblinding of the patients. If you're going through all the symptoms that you think you're going to more likely have on ketamine than midazolam to measure the sort of this effects of treatment, I think it also helps to sort of coach the patient repeatedly on what to expect in the infusion, which I think is a bad thing.
Yeah.
And then I think we also know that there's going to be significant dissociative effects, and it'd just be better to measure it after the fact.
And I also think like it doesn't capture a lot of phenomena, which might be quite important, like a kind of sense of peace. Yeah.
Cool. Yeah. So Silvana's come back saying, what about ethics approval, patient recruitments, and interactions? How did that go with the adolescents? Just actually running studying them.
I'll hand that over to you.
Okay, so I guess so we worked really. So this was I think the environment when we started this study was a lot less welcoming than it is now. Just we started the study maybe, I forget the date in the paper, but it's got to be like 7 years ago or something like that. So it's pre-ketamine approval, and so I think the Yale IRB was great. We went and talked to them before we were going to do this study. I think I think they were very we're mostly sort of medical, non-psychiatric people, but I think they really bought the argument that suicide's a major public health problem in adolescents. We don't have effective treatments. We need to try something. There's good data that this works in adults. We should try it. I don't think that has been again, we've definitely had some adverse outcomes, including completed suicides in sort of the follow-up phases of the trial. But I think the IRB has been really, I think, thoughtful about it and has not been a significant issue. The FDA one is the one I would say was a significant issue that affects how we do our studies.
Yeah. And Julia raises the issue about malpractice has changed for some providers, no longer covering ketamine for under 18-year-olds and Spravato not being approved for under 18. I guess that's just in the clinical domain. That's not not relevant to the research domain, but any comments on that? No. Okay, well,
I'm lucky enough to have Yale pick up my malpractice insurance, but I think, again, I mean, I think you give people the information, you give them the alternatives, and I think it's an option, and I think non-treatment has significant risks. And I hope to help the families even if the kids don't respond to the ketamine.
So Suraya Rahman says there's a study that's been completed at Radi Children's for suicidal ideation in the ED in adolescents.
Hi.
Do you want to tell us about that?
Yeah. Hi, I'm a pediatric physician working in ketamine assisted psychotherapy, and actually connecting a group of practitioners in the US called IACAP, Adolescent and Young Adults, undergoing ketamine assisted psychotherapy. And so really bringing together this group that this work that you guys are discussing. So one of the physicians, Dr. Tanya Van Gorten, she's an ED physician in the pediatric emergency room at Rady Children's in San Diego, and was able to get through the IRB approval for a 0.2 mg per kg dose. That was what she was able to get through their IRB, but she was able to push something through. It took her a year to do that. And she's just completed the recruitment, has data, and is about to enter the analysis phase. So I just wanted to put that out there, that there is a group of us in the United States very, very interested in this medication. I come from the pediatric sedation background at LA County Hospital. So in the last 10 years, very, very, have given this medication alongside other medications in the ICU, in the OR, in the ED. And it's, when you're talking about this moment where we're in, where it's like, well, what's the risk benefit ratio of giving ketamine to an adolescent who is acutely suicidal? Well, let's look at what the risk is of not giving ketamine to an adolescent who's broken their leg and needs this medication to go through, an acute procedure in the emergency room. And we know that we can give ketamine to children, down to neonatal age in the ICU for days to weeks. I've personally seen a child in the ICU, succeed with ketamine for a 3-week infusion for seizures. So I think when we're talking about adolescents and we're really trying to claw at the FDA and all of these approvals, really bringing in the sedation aspect, bringing in the fact that we've been using this medication in children to a very young age for a long, long period of time safely in all these different ways that we've done it, has to enter the discussion. Because unless we, so I was just looking up if ketamine has been mentioned in this pediatric sedation consortium that exists in the United States. And they have 4 references on there, and they are talking about body surface area being one of the considerations in pediatrics that we need to. So Sarah, thank you for bringing that up, that I think in pediatrics we have to be really hone it down to, okay, what dose is each person getting and how much of a mgs per kg does that denote to them? Because a 70-kilo 15-year-old and a 50-kilo 15-year-old are going to be very different. And so really even thinking of that piece when we're talking about pediatrics is really important. Stop there. But a few of my other colleagues are on here as well, and we're really interested in this conversation that you're having. So thank you for having me.
That's great. Thank you, Sarah. Can you just mention you spell the name of the surname of Tanya's surname, so the PI?
Oh yeah, I'll write it down here.
Thanks. Yeah.
I'm curious if anybody knows of any similar studies going on with adolescents in the UK.
I'm pretty confident there aren't any. But
does any private treatment happen that you know of, Rupert?
Well, we do some. Yeah. And
why do you think we're so far behind the US?
We're far behind the US in all sorts of things. They're the land of the free, and and we're very risk averse. And the NHS is a highly risk averse institution. So I think that's probably I mean, I'm quite sure that Michael's probably going to say that everybody in the US is very risk averse. Your institutions are risk averse too, but you ain't seen nothing yet.
Yeah, and I don't. I think there are a lot of things I really admire about the NHS, but I think they're probably. I'm in a very good institutional environment in terms of being supportive of the research, and I think that makes a difference. I think where we have hit the regulatory issues, it's been with the same sort of stuff, with the sort of the FDA and governmental stuff rather than Yale specifically and IRB stuff, and I think that is not super surprising because they're also extremely risk averse. And I guess the one thing I sort of have trouble with about the risk averse stuff is that there's a risk to not treating these kids and not developing treatments too, that I think is a pretty significant issue. And then there's also risk when it's an off-label treatment where a lot of people are giving it out, off-label multiple times, and so you have this situation where I can't collect the safety data that I think would be important to inform on that. Because if you're really concerned about, ketamine, repeated doses of ketamine having an effect on kids, which I tend to agree with the conscious sedation anesthesiologists in the audience, that it seems to be overstated, but that's my personal opinion. But that you'd at least want to get some signal from the people who are being studied in the community. And
the lack of a sort of platform for collecting the safety data, I think, is shocking, really, and it's very hard because there's no institution that is prepared to fund that, and it's quite a significant funding issue.
And I guess the other issue is if you're going to do it outside the context of a clinical trial, big issues, then you don't have control of the dosing and the frequency of the ketamine anymore. And I think that's it, and so then it introduces too much noise to really know what's going on. Because of course, the kids who are going to get more treatments in the community, well, I won't say of course, but they'll probably have worse outcomes because they'll keep needing the treatments, and they will have, you can make a case that it may be related to factors unrelated to the ketamine.
Yes, and it's hard to stop, isn't it? If somebody gets a sort of small improvement, they're very severely ill, you give them ketamine, they make a small improvement. At what point do you give up? And those are very difficult decisions, actually, I find.
Yes, but it's an entirely answerable question with data.
Of course. Yeah.
I would definitely like to include that in this discussion as adolescents. We're talking about development as well. Adolescent depression is different than adult depression. That one key way is it makes them get stuck in a developmental stage. And so one of the reasons why I think ketamine in adolescence takes so many months is not the ketamine itself. It's just that we are holding space for them until that development that was going to take place takes place, which can be 12 to 18 months and even more, so they can get to that state change. And that is where you're right, that what surrounds the child, and the family. What we're learning is the family dynamics really play into it. I think Dr. Wolfson's data on that was very clear, that when we're able to bring family in, when we're able to wrap them into the treatment protocol, these children will do better, just because we're treating the entire family system versus just the adolescent. Because a lot of times adolescent depression is, the child is feeling the issue that the family is carrying and creating, and it is just expressing itself in the adolescent. So that's that piece that's very interesting in adolescent depression as well.
That's great. And thank you, Soraya, for putting the contact details of your regular sort of equivalent to this, I suppose, second Fridays at 8 a.m. PST. That's a great resource there to start ball rolling.
Thank you. We're definitely working on the advocacy piece this year, and we hope that we can gather the data that we are you know, a lot of our practitioners are gathering from doing this work out in the wild, as we say, outside of academia.
Yeah. Okay. Well, gosh, we're over time already. So we're going to have to wrap up. That's a great discussion. Thank you very much indeed, Alice, for leading us through your study. Congratulations on getting that, seeing that through, and that's obviously a nice project to have landed when you got to Yale. So that's terrific.